How is one clinician thinking about applying AI to healthcare in additive ways that improve access to care, clinician confidence, and patient experience? Find out on today's episode.
I'm Dr. Carla Goulart Peron from Philips, and you are listening to Me, Myself, and AI.
Welcome to Me, Myself, and AI, a podcast from MIT Sloan Management Review, exploring the future of artificial intelligence. I'm Sam Ransbotham, professor of analytics at Boston College. I've been researching data, analytics, and AI at MIT SMR since 2014, with research articles, annual industry reports, case studies, and now 13 seasons of podcast episodes. In each episode, corporate leaders, cutting-edge researchers, and AI policymakers join us to break down what separates AI hype from AI success. Our guest today is Dr. Carla Goulart Peron, Chief Medical Officer at Philips. Philips is a healthcare technology company behind imaging systems, patient monitoring, and a growing suite of AI-based clinical tools. What I find fascinating about Carla's perspective is that she started her career as a physician in Sao Paulo's public health system, where demand far outstrips resources. She's carried that lens into the C-suite. She's now leading medical strategy for a company that's betting heavily on AI to close gaps in care. Carla, welcome to the show.
Thank you very much, Sam.
Many listeners might still associate Philips with more consumer electronics, but can you tell us about the company in terms of healthcare and the kinds of things you're doing?
Yeah, of course. It's indeed a company that has 130 years and has been in many areas. But in the last few decades, Philips shifted into healthcare fully. We start with the imaging, so the diagnostic area, X-ray, CT, MRI, ultrasound. And then we go into the interventional therapy, into the cath labs. We also are very much present into the ICU and any area of the hospital where you are monitoring signals coming from those patients. Also heavily invested in monitoring things outside of the hospital as well. And then the last piece, but not less important, definitely AI that is supporting all those areas of care and then keep growing, in a very hot topic right now.
Yeah, as you were listing these technologies, I was thinking, those are classic applications where AI has made huge advances with imaging and these sorts of things. I mentioned earlier, you trained as a physician and you worked there in both the public and the private sector, sometimes in the same day, I think, switching back and forth. So what did that experience teach you about where healthcare breaks down in a way that maybe technology can help?
You are right. In the morning, I was working in the public sector in Brazil where scarcity of healthcare workers, technology, information sometimes is very much present. So you need to work with the best of your capacity to offer care for those patients. But it's a universal healthcare, which means everybody has access to. So there is a benefit there too. And sometimes in the afternoon or in the night, I was working in the best of the best hospitals in the private sector with everything available. So I think that teaches you a lot of resilience personally as an individual, as a physician, but also you give you the chance to try different things and learn from those experiences. But also makes so much clear to an individual like me how much technology can actually build a bridge and help support more patients that are expecting to get access to healthcare overall, right? Whatever it is, because it's expediting the way you are seeing those patients, because it's connecting the data points of information, or even allowing collaboration across the specialties that may not be present in the public sector.
So was there a specific moment that you just said, this is something that technology could really help with or could help fix? Was there anything that sort of made you think technology might be the answer?
Oh, many times, but I love sharing an example of ultrasound. But I was just coming out of residency, actually, and starting to see patients on my own. And ultrasound, it is one of the biggest diagnostic tools that we use in the OB/GYN practice. But not always we had access to those machines in the hospital setup. And sometimes we had access to those machines, but we are not qualified to use them. And so technology came into reality today, and I'm very jealous about the people that are learning today their own clinical practice in a way that you have clear collaboration. And so you can really open the technology, open the ultrasound machine, get access to an expert that can be anywhere in the planet, right? Let's just say in the same city, just to make it easier from the clinical practice perspective. to guide you to see what you are seeing, that same imaging, help you to capture the right imaging and kind of expedite the technology that in some other places, like the ones that we're practicing in the public sector, I would need to transfer that patient sometimes to another facility, which means call an ambulance, be stuck in traffic, just to get the image capture and then patient back for you to be able to take a final diagnostic and initiate therapy. So, I mean, that was like wine and water, unfortunately, between those two worlds that I was living in.
Yeah, you mentioned the traffic. Not too long ago, I was in Sao Paulo, and that was a big thing I remember there, is just how long it took to get from one place to another. But actually, ultrasound are these even more expensive machines that can't move. But then there's also the other parts, that information that can move. And I think you were sort of making a distinction between those. You've got some aspects of what you're doing that seem to rely very heavily on sophisticated equipment. At the other hand, you also have information which can flow without that bottleneck of Sao Paulo traffic.
Yeah. I mean, I mentioned ultrasound, which is highly dependent of the imaging that you are actually seeing on time, right? So you use that imaging on time to kind of make the diagnostic. But when we think about CT, right, or MRI, they produce hundreds of imagings, right, that the radiologist can see from anywhere. And that is also facilitating drastically the way that we are actually reporting imaging. Also, you are highly dependent on the users that are actually placing the patient into the machine, making sure that the patient is well positioned, that is holding the breath if needed, or that is kind of moving accordingly. And now with AI coming on board, you also can get that done very quickly, precisely, with not much support or training from the technical perspective. So that has been also a game changer. I would say the way we are leveraging technology, AI, automation, to position those patients, to make sure that the exam can be as fast as possible, but also how we are processing the imaging that is coming out of those big machines has been very different.
Okay, so I think I was too simple. I was talking about the machine and then the result of the machine. But actually, you're bringing up an important point, which is there's also a knowledge transfer and an information transfer about how to get the best image in the first place. And I think I glossed over that. But you started bedside, but now you're running medical strategy for Philips. How does that inform what you think about the healthcare strategy and how that works, your deep background in actual doing medicine?
You know, it's interesting because I think when you go into med school, most of the people that decide to take this pathway don't think about anything different than just seeing patients on a one-on-one basis, right? At least when I start med school, that was the reality. I think today is very different. But in that journey of understanding the healthcare system, how companies that are developing drugs, medical device, or other types of equipment work, I ended learning that there is a role to play in this industry side and the corporate side that can be as rewarding and as interesting as seeing patients on a one-on-one basis, probably in a much bigger scale. So I think I needed to convince myself that by moving from the bedside into the corporate, I was not changing my background as a physician, or I was not leaving my professional behind. I was actually just applying that knowledge in a different way. So I'm fascinated by innovation. I'm fascinated to ensuring that whatever innovation we are investing on in the corporate environment can actually reach the patients that are going to benefit most. And that's really the biggest part of my job, right? Ensuring that the ideas that our engineers are developing in partnership with hospitals and physicians are going to meet the requirements of the regulation, because we need to prove that it's safe and it's effective, right? But also that we will have a good plan in how this technology can be incorporated by the healthcare system in the way that can actually reach the patients that are going to benefit most. It is different. It's very different, but it's fascinating because I keep learning every day, because it's new technologies, new areas of care, right? New types of healthcare systems. If you think about a company like Philips that has a global presence, it's very different to think about commercializing something in Brazil than is in the US or in Europe or in Africa or in Asia. So you need to have that kind of globalized thought in mind when you are thinking about developing technology.
Well, let's talk about some of these specifics. I think Philips just got FDA clearance for Smart Heart, which is a automated cardiac MR planning tool. First, explain to people like me what that actually means, and then how does that actually change a radiologist's day? What's different?
Yeah, so Smart Heart is a great example, right? As you think about a MR machine, it is a technology that can capture imaging from your entire body, right? So in order for you to do that, you need to have a technician that understands exactly why you are actually being requested as a patient to do that exam. So in this case, physician, a cardiologist most likely, want to actually see how your heart is functioning. So imagine that a technician needs to know exactly how he or she should be positioning you into the MR table, in which angle, if you are tall or short, if you are someone that is big or small, if it's a kid or if it's a female or a male. There's so many different data points that a technician needs to understand in order to capture the right level of imaging with the right quality, that a radiologist can actually do a diagnostic out of it. Smart Heart is an AI-driven, one-click automation that plans all setups that drives how the cardiac imaging needs to be captured. And this happens in 30 seconds. So that sounds like simple, but for the operator that is actually doing multiple exams in different parts of the body with different indications, that can be from 15 minutes to 30 seconds. It makes the machine a lot more accessible. It makes the technician capable of doing a lot more exams, and also reduce the dependency of having someone that's highly trained. So the burden on the technician is really also something that today is a big issue out there.
I like the idea that we have a very expensive machine that we can increase the throughput for. Like you said, 15 minutes, that's 4 exams an hour, even without any setup and putting on the gown. But you talk about 30 seconds, and that suddenly I feel like, hey, we have an expensive machine that we can use a lot more.
It is definitely, right? Speed. There is a burden on healthcare providers and nurses, physicians overall, but also first time right? So sometimes if you don't have something like this, you go through the exam, send the images to the radiologist, and they will say, oh, you need to call this patient back because we are missing 1 or 2 views. And with something like that, this doesn't happen.
AI isn't just a technology shift. It's a leadership test. The real challenge isn't adopting AI, but knowing how to apply responsibly, productively, and at scale. Led by MIT faculty at the forefront of research and practice, MIT Sloan Executive Education offers a portfolio of AI-focused courses, in-person and online, designed for leaders who are building AI literacy across their organizations and rethinking expertise, productivity, and governance in an AI-driven world. Learn more at executive.mit.edu/AISMR. Yeah, nobody likes that. I mean, nobody wants to go back and forth and
especially
and
on a machine that it's kind of like you don't want to be there. It's small, and somehow it may not be that comfortable for the patients overall.
But I think about radiology, and radiology is one of the areas that I think a decade ago people were saying, "Oh gosh, we're never going to have radiologists again because the machines are going to do everything." And that narrative has really not played out at all. But I think it's a great example of just sort of in general how artificial intelligence might affect the future of work and what we do. But is there a risk that if this process works too well, hospitals are going to start thinking they need fewer radiologists? How's that going to play out, do you see?
Yeah, I personally believe that AI is here to add, not to take over. Maybe this conversation will be very different in 5 years from now, because I think we're learning that environment.
Predicting is so tough in this world.
But I think on the radiology space for now, radiologists are wasting their time in things that are not valuable at all. Reviewing images that were not captured precisely, or doing reports, or reassessing a lot of normal images. Interesting enough, a few weeks ago, I was with one of the radiologists' medical societies, and they were talking about what if we could have AI defining all normal images, and then radiologists will be looking at only abnormal. And what's fascinating about AI and the potential, someone in the audience raised their hand and said, well, how are we going to get the radiologists trained in what is abnormal if they're not going to be seeing normal? So I think the answer for your question is still TBD in somehow, right? So what the future will look like, to your point. But I don't see AI taking over. I think it's actually helping us to see more patients because there is a big gap out there. Also to be dedicating our time to things that are unique that we can do as clinicians.
Yeah, one way I think about this is we would have a very different story if every possible patient in the world was completely satisfied with a perfect supply of radiology. Like if everybody that needed this treatment was currently getting it, then I think we maybe could be talking about this replacement type of thing. But I mean, you know far better than I do that that's just not the case. There's massive undersupply of these type technologies, and a lot of it is driven by the certain return on investment and the cost structure now, which I believe this can change. Like, how do you see that aspect changing in terms of serving more?
I personally believe that there is such a big gap out there in access to care that as we incorporate technology, we'll be able to do more with the same, not with less, right? And because I was born and raised in Brazil and practice in Brazil, I feel very comfortable in going that pathway on low-income countries. In those areas, the gap is really huge. You can be waiting in line for months in order to have, as an example, an MR or a CT scan done, right? Sometimes too late in the game that actually can change the patient outcome. But we cannot fool ourselves that reality also exists in the US and in Europe and in Asia. We have deserts, right? We have areas where people don't have any access to care. So I don't personally see a timeline where I would say, well, this will quickly fix that gap in a way that is going to be reduced.
Yeah, I love the idea that what this leads to is better matching of need with supply. I've got a beef to raise with you. You had this future health index that you had put together. Normally, I like to skim these things before a call, but it was actually quite interesting. So it cost me a lot more time looking at it than I wanted. But I think part of your finding in that future health index was that 79% of the healthcare professionals are optimistic about AI, but like half of the patients are worried that it's going to reduce their face-to-face time. How are we going to reconcile these two different perspectives from a market that has both parties are important?
I think the perspective of the patients is very important in this one, right? If the patients start to feel too uncomfortable and reject AI, it may become a challenge. I also think that this is slowly changing, and we're going to be launching a new version of the assessment a little later this year. But for me, the ability to reconcile those two things from the healthcare professional perspective is ensuring that we're validating, we're getting good access to data that is actually being used to train the machines, right? So physicians are on board, but really a little bit cautious about how much eventually bias do I get in the AI? Can I trust fully AI? How much do I need to review what's happening? So I think in the physician perspective or the healthcare workers perspective, it's more towards data-driven. While in the patient perspective, I think it's more about the experience. And I think AI became like a big buzzword. And so people don't know exactly what to expect. So there is this misperception that physicians are going to be substituted by machines. While the reality is the physician's time is actually being freed up to be actually dedicated more to the empathy piece, to the touch, to that one-on-one eye-to-eye, which I think it's going to make a big difference. But at the second point, what I think it's very interesting, there are some studies already out there that show if you are talking to a real physician or to an AI version of that physician, sometimes the AI can learn how to be more empathetic than the physician. So I think this is going to be a journey of us as individuals actually learning how to incorporate AI into our lives and trusting a little bit that help that I think we're going to start getting for future.
In our research, we found that like individuals who trust AI are twice as likely to use it regularly. That trust is an important part. But when we were studying it, we were sort of thinking in general, just use of AI. It strikes me that that's different about trusting Netflix's recommendation versus healthcare. But perhaps there is something transferable between the consumer levels of artificial intelligence and the greater understanding there and healthcare. Is there something unique about building trust in this clinical setting that is different than my Netflix example?
I think people are more concerned about their health, right, than eventually getting an advice of which movie I should be watching or which series. But one of the areas that I think AI is actually already doing for the patients is enabling, right? So I think even the name we gave to that individual that is in the center of everything we do as clinicians, patient, it's almost like you stay there, be patient, and wait until somebody tells you what to do. While now with, first of all, AI enabling interoperability data points, you are giving more visibility to the overall health. And also, what are the options that those patients may have in front of them? And I think this is, in my view, is going to change drastically the way that we, physicians and patients, will be embracing healthcare for the future. Because I think, I went to med school many years ago. Patients didn't have a say. It was really, that's the protocol and that's what we're going to do. And you just follow it. I think more and more we're starting to talk about precise medicine, where patients will be able to be offered 1, 2, 3 potential treatment pathways with pros and cons and the ability to choose. And I think AI may enable those patients to kind of make more informed decisions at least.
Actually, I really like the framing of the word patient because I feel like I often am not. We had Josh from CVS on. One of the things we got into was, hey, I just would be, forget all this AI stuff. I'd just be happy if I didn't have to put my name in over and over again and wait for a long time. You can talk about all the cool AI stuff you want to, but let's get some of those simple things done. I think you're very focused on women's cardiac health. Maybe just orient us. What are some of the specific gaps in care for women, and how do you see AI perhaps connecting and either exacerbating or helping with that?
Yeah, I'm very passionate about the topic because I always say we need to remind people that we're not mini men. We are different as women, and we do have a heart, and it needs to function like any other heart in the man's body. So there is a big gap. Cardiac cases are the highest mortality rate present in female. Despite that, female have a much longer waiting time until to get diagnostic. Because we experience symptoms different sometimes, because most of the protocols that have been designed based on studies that included only male. So there is a big gap out there that needs to be covered. And what technology definitely can help in kind of covering that gap is ensuring that the nuances and the differences in the physiology and the type of response that female used to present is actually incorporated into the way we are designing the diagnostic tools. We talk about MR, right? So the position of the heart is slightly different in the women's chest compared with the men's chest. It's a very detailed minor thing, but it can impact the way you're capturing your imaging. If you are capturing cardiac rhythm, for example, right? So the algorithms needs to understand that the female heart has a pattern that's slightly different from the male heart. And so I think AI will quickly get that information into those algorithms because of the speed, right? And be able to equalize that.
And that sort of presumes the fact that we've got these perhaps underrepresented or undertreated populations within our data sets. We had Ziad Obermeyer on the show a couple of seasons ago, and he was talking about how these algorithms can actually build up this equity, but it was depending on having that raw data to start with. What can we do to try to get better sampling on those underrepresented populations?
So the first thing is what we are doing right now is talk about it, right? So there is an opportunity for us to do better now. So you are spot on, right? So most of the drugs are developed based on a very limited number of female or even other diverse type of population, right? You name it. The same thing for medical devices. And most of the protocols and guidelines that are created are also created based on trials that were developed a long time ago, which didn't necessarily include the right level of variety, right? That's the first point. The second point is that using technology and AI to capture that information pretty quickly and reiterate rather than starting from scratch. I've learned a big lesson 2 years ago when I attended the WEF for the first time, and we were talking about women's health. And I'm OBGYN. I have more than 20 years of clinical practice. And someone was telling me the story that when a woman gives birth, there is a standard that defines that 5 milliliters of blood lost is normal. So if you have that, you don't need to take any actions. And then I heard a question from the audience during that WEF discussion. How was that established? And I paused because I never asked that question. I'd never had the curiosity. That wasn't the book. I just kind of assumed that a very good methodology was put in place. And that standard was developed based on 9 female in Germany and exploited and used in the entire planet. Can you imagine how that translates to India or China, where they are much smaller bodies? So they quickly were able to iterate that with data points and kind of creating a good correlation and establish that in India, that number should be 300 milliliters. So that makes a huge difference in how you're going to be treating your patients. And I think technology, that interconnectivity, that not only the fact that we're going into automation, right, but that now AI can analyze such a big data set so quickly can really improve the way we are practicing medicine.
Actually, that's an interesting example because it strikes me as a slightly different approach, which is, in your example, you had to go to the World Economic Forum to have that question get raised. But I don't know, somehow I can also imagine a very simple job for agents would be, hey, go through all of our clinical practices in every area and find the root study for that and assess how that plays out. I would feel like your 9-person in Germany sample should rise pretty quickly to the top of that list. That seems pretty exciting.
Pretty exciting, exactly. It's fascinating what can be done. Yeah.
Let's look forward for a minute, though. You started in public health in Brazil. There's a lot of resource constraints there about technology. If you could pick one AI capability to deploy globally that would make the biggest difference, you get to choose right now, wish list. What would you push out to the world? What do you think is our greatest application of the use of artificial intelligence in healthcare that we could push globally?
Interoperability. That is going to change completely the way we practice medicine. Because today we're very much closed or restricted to the healthcare system that you are operating. So the ability to kind of see the patients longitudinally without those barriers, I personally believe is going to change outcomes significantly. If I need to pick one, that will be my choice.
That's not at all where I thought you'd go with that. That's pretty fascinating. It's so cross-cutting and it affects everything. All right, so I'll bite. What's the biggest barrier to that actually happening?
Oh, that's a big question. That's why it's a dream. You said you can pick anything, don't get restricted. I think there are many, right? So the first one is making sure that we have access to good quality data, but also that we start thinking about that from the get-go. If you don't have some level of standardization, it's very difficult to think about interoperability. I think that's the first piece, which is science. It's how we drive this for future. The second is how we think about incorporating this new era, well, how we think about incorporating reimbursement and access to technology into the discussion about AI. We are still restricted by the reimbursement systems. What kind of code coverage do we have? What is the incentive? We may have something that can actually pretty quickly take the patients out of the hospital, right? Reduce length of stay. But if that's not the incentive from the healthcare system perspective, this is not going to happen. So for me, that's another big thing that we need to think about. And the other piece, which I think it's how we need to partner, is regulation. Regulation will need to evolve with this new environment that we're getting into. The type of regulation that brought us here is not going to take us to the future because the future is very different than the one we are playing today.
That seems really hard too, because yes, we built this regulatory system and we built these reimbursement processes and so many processes we built off of the way things used to work. Thank you for joining us. I think what really comes through so clearly is that this just isn't abstract for you. This is something that you know deeply, and you've seen what happens when care isn't accessible. And I liked some of the ideas that you mentioned about how do we make the use of technology, not just AI, but technology in general, part of the solution and not just sort of a headline. Thanks for joining us.
My pleasure, Sam. Really appreciate the conversation.
Thanks for tuning in today. On the last episode of Season 13, I'll be joined by Bernard Hampton, a corporate learning leader at Bank of America. Talk to you then.
Thanks for listening to Me, Myself, and AI. We believe, like you, that the conversation about AI implementation doesn't start and stop with this podcast. That's why we've created a group on LinkedIn specifically for listeners like you. It's called AI for Leaders. And if you join us, you can chat with show creators and hosts, ask your own questions, share your insights, and gain access to valuable resources about AI implementation from MIT SMR and BCG. You can access it by visiting mitsmr.com/AI for Leaders. We'll put that link in the show notes, and we hope to see you there.